Hello, everyone. Apologies for the technical difficulties and thank you for staying on board for this. My name is Ed Bottomley from the Michigan Medicine Department of Communication, and I will be your host for today's live stream on COVID-19 and kids. A small number of children appear to be getting sick from COVID-19, but we are still learning more about how the virus affects kids. New reports also suggest that some children are experiencing symptoms of a rare disease called multi-inflammatory syndrome, MIS-C, believed to be connected to the novel coronavirus. Today, our experts will help us answer parents' top questions on these subjects. And before I get to our experts, just a few housekeeping items. You can submit your questions at any time, even now, for our experts to answer during the Q&A portion of today's chat. Questions can be submitted by commenting on this video, but please do note that your name or your profile name will be visible to others participating. If you prefer a more anonymous option, you can also send a private message or email us at ask-mishmed@med.umich.edu. I'll repeat that, ask-mishmed@med.umich.edu. If you can't stay for the whole chat, or if you want to share a recording of this chat with a friend, a video of this chat in its entirety will be available on our Michigan Medicine and CS Mott Children's Hospital Facebook pages, our Mott Children Twitter account, and the Michigan Medicine YouTube channel as well. So, after all that, let's move on to our experts. We're joined today by our experts, Dr. Elizabeth Lloyd and Dr. Gabe Owens. If we could have both of you just introduce yourselves, just tell us a little bit about your areas of expertise. Dr. Lloyd, if you could go first.
Hi, everybody, and thank you for having me here. My name is Elizabeth Lloyd, and I am a physician in pediatric infectious diseases at Michigan Medicine CS Mott Children's Hospital, and my area of expertise is antimicrobial stewardship.
Hi, I'm Gabe Owens. Thanks for having me as well. I'm a pediatric cardiologist and a cardiac intensivist here at Michigan Medicine, obviously specializing in kids with heart disease.
Fantastic. So let's move on to our questions. The first one that we have up is, we know that with common respiratory viruses like the flu, children and people over the age of 65 tend to be more severely affected. How is the new coronavirus different? Specifically, what have we learned about coronavirus in kids?
Sure. So with this new coronavirus, we are still seeing that the older population, so those older than 65 to 70 years old, are the most affected. But interestingly, children really haven't been as affected by this virus as they are by many others, such as the flu. Both the Michigan the Michigan Department of Health and Human Services, as well as CDC, have tracking data, and both of them are showing about 2 to 3% of cases of COVID-19 are in children less than 18 years old, despite this age group making up a much larger percent of the population as a whole. So about 22% of the US population is in this age group. That's also consistent with data that we've seen from other countries, including China, Italy, and Spain. And additionally, in contrast with adults, children are, when they do get sick, they tend to have either no symptoms or only mild to moderate symptoms. When they do have symptoms, it tends to be similar to adults with fevers, cough, shortness of breath, fatigue, sometimes nasal congestion, sometimes sore throat. Overall, children have a great prognosis with this infection. In total, they've made up less than 1% of death.
Thank you for that.
I might add as well that is paralleled for what we've seen here at Michigan Medicine. We've had very few pediatric patients affected by the condition. And even those children, so to speak, that are affected are usually the older ones in adolescents that have more severe illness. It's the younger children seem to have a less severe symptomatology from this condition.
Thank you for that. Our next question up, how often are children getting severely sick from COVID-19, and are certain groups of children more at risk?
Yeah, so we've seen data come out, and it varies a little bit depending on what source you look at. But of children who have confirmed COVID-19 infection, only a minority, so between 6 and 20% of those children are requiring hospitalization, and really only 1 to 2% are requiring ICU level care, which is very different from what we're seeing in adults, where much higher percentages of them are getting much more sick. And then of the children who are admitted to the ICU, very few of them are dying. So we are still learning about exactly which risk factors might play a role in children with COVID-19, but we think that it's likely fairly similar to the risk factors that have been defined in adults for severe disease, which includes a lot of chronic illnesses such as chronic lung disease, chronic heart disease, kidney disease, liver disease, immunosuppression, diabetes, or obesity. Fortunately, those children who do get sick still are recovering very well.
Thank you for that. Our next question, what does the data tell us about why children may be more resilient against the virus compared to adults?
So this is an area that we don't fully understand yet, but there's a few theories which I can talk about. So in general, as I mentioned, we know that certain underlying medical problems can cause more problems in adults who get sick with COVID-19. And so we think that it might be at least partially that children tend to be healthier. Children tend to have less of these chronic medical conditions, and so they may do better, at least partially from that standpoint. Another theory is that, so this may be the first time that many of us have heard about coronavirus, but coronaviruses have been around for a long time, and they tend to circulate heavily in children. So it's theorized that children who have maybe recently been infected with a different type of coronavirus, they may have developed antibodies that could provide some cross protection against this newer coronavirus. Again, these are just theories, but things that are being investigated and may make sense. A couple other things. So one is we know that coronavirus binds to a particular receptor that's present on the respiratory cells in the respiratory tract. And it's theorized that this receptor there may be more of these receptors in adults than in children, which then allows for more of the virus to bind and cause infection in adults than in children. And the last one is that with a lot of the adults that are getting very sick, we think it's because their immune system is overreacting. And there's theory that children, because they just haven't, their immune systems are less developed, especially the younger children, they may not be as prone to having this overreaction of their immune system. Of course, I think now we'll talk about MISC a little bit later, and that's kind of throwing a different spin on things. But those are some of the theories that are out there as to why children tend to do better with this disease.
Thank you for that. The next question that we have up, what do we know about how likely children are to be the ones spreading the virus compared to adults?
So I think early on, there was a lot of concern that children would be a very important vector for viral spread, in part because, as we know, children don't always abide by proper social distancing or hygiene measures just by virtue of being a child. There was also some concern that children who were asymptomatic, meaning had no symptoms, could be spreading the virus around without knowing it. However, at least at Michigan Medicine, so we have been testing all children who have been admitted to the hospital for a little while now, and we're seeing very few numbers of those children who don't have symptoms test positive. So that's reassuring that as of right now, at least, there's probably not a ton of asymptomatic children running around with this virus. However, as daycares open back up and schools potentially open back up, that may change, and that's something we're going to have to pay attention to. But for now, it really seems like adults, because they make up such a high proportion of the cases, adults are probably the ones that are currently spreading the virus more.
You mentioned a moment ago, Dr. Lloyd, that we will be moving on to questions about MISC, multi-system inflammatory syndrome. So we're going to move into a few questions about those now. First one, what do we know about the new multi-system inflammatory syndrome, and should I be concerned?
So in general, I would say this seems to be very rare. We're still learning exactly how prevalent it is, but it seems to be a very uncommon condition. So it's not something that I think everybody should be concerned about or worried about. People should be educated and know what to look out for, but certainly shouldn't cause panic at this point, as far as that question goes. And Dr. Owens, I don't know if you have anything you'd like to say before I can start talking a little bit more about what we know. With anything from your perspective?
I think you said it very nicely, that we want to be very aware that there's a condition that is being reported and people are seeing. It is a very rare condition that we know of right now. So we want families and medical providers to be aware and be observant, but not to panic. But we certainly want to start evaluating children that might have this condition that we'll talk about in a second, on the earlier side rather than the later side, so that we can give them the appropriate therapies to get them through it.
So what we know so far is that there have been children reported with this inflammatory syndrome. There's a range of reported symptoms that go along with this. Most often children will have prolonged fever, so on the order of 4 to 6 days of fevers. Some of them have symptoms that are very similar to Kawasaki disease, which people have probably been hearing about in the news as well. And that those symptoms can include skin rashes, conjunctivitis, which is kind of red or inflamed eyes, mucous membrane changes, so that would be red, swollen, or cracked lips or tongue. Some children have sore throat or headaches. Many of them have gastrointestinal symptoms, so that being abdominal pain or vomiting or diarrhea. Interestingly, compared to actual infection with the COVID virus itself, very few of these children with MIS-C have respiratory symptoms. So it really seems to be a different phenomenon. And then when children do have their blood work done in the lab, their lab work shows high levels of inflammation in their blood.
Fantastic. Thank you for that. We have a number of questions, some of which you've touched on a little bit, but I think they bear repeating. So the first one we have here, I've seen references to PMIS and MIS-C. Are these the same?
Yes, so these are the same thing. And the way that it kind of evolved was that at the end of April is when we first started hearing about these cases out of the United Kingdom. And so there was, and Italy, there was an alert by the Royal College of Pediatrics and Child Health in the UK, and they first referred to this syndrome as Pediatric Multi-System Inflammatory Syndrome, temporally associated with COVID-19. So that was being abbreviated PMIS or PIMS. And then it was on May 14th that the CDC sent out a health advisory that referred to the condition as multi-system inflammatory syndrome in children, or MIS-C. And that's also the name that the World Health Organization is using. And really that's become the preferred name for the syndrome now, but they are the same thing.
Fantastic.
But we can see where people are confused because there's ever-changing acronyms for this condition. So even us in the medical community are trying to keep up with the ever-changing abbreviations.
Absolutely. We've also touched on this a little bit, but again, let's circle back a bit. I've heard MIS-C compared to Kawasaki disease. What is the connection?
Why don't you go ahead and start, Liz, and then we can
Sure.
go from there.
So as an infectious disease doctor, I'm certainly not a Kawasaki disease expert. But what we do know about Kawasaki disease is that it can be triggered by a virus, and it's actually been shown to be triggered by other coronaviruses. And so I think one of the initial questions is this actually Kawasaki disease that's being triggered by this coronavirus, or is this something different? And my sense is that this is something different, and there's several reasons for that. But it really seems that it is kind of a different inflammatory syndrome that is being triggered by the virus, but has a lot of overlapping features with Kawasaki disease.
So when we think about Kawasaki disease, it's a febrile inflammatory illness in children. A lot of its components are things that we're seeing with MIS-C, in the sense that kids have prolonged, persistent high fevers. They develop a rash, reddening of their eyes or conjunctivitis, can have cracked mucous membranes, cracked lips, redness of their palms and their hands, peeling of their skin, swollen lymph nodes, et cetera, et cetera. So there are a lot of similarities, as Liz just mentioned. Some of the other conditions that Kawasaki disease causes is some inflammation of the vessels in the heart. And we are seeing some of that in this condition associated with COVID-19 as well. But they do appear to be distinct in their disease process from various factors and symptoms that patients are presenting with. For one, Kawasaki disease is typically seen in young kids, kids under 5 years of age. Very rare to have a complete Kawasaki disease in a child above 5 or 6. And we're not seeing that with this MISC. We are seeing older children being affected by this disorder. So there's a variation there as well. Children with Kawasaki disease they're very angry, they're very irritable because they've got a high fever and they're inflamed, but they're usually pretty healthy in the sense that their vital signs are pretty stable, and the things that we're doing are really to prevent long-term complications. With MISC, we are seeing children, and again, a very rare condition to get, and even more rare to have significant vital sign aberrations from it, but we are seeing children have cardiovascular effects that are a lot more severe than Kawasaki disease. These patients might need some medication to maintain their blood pressures and more cardiovascular support, again, in the most rare condition, but that's a deviation from Kawasaki. Another symptom that we want families to be aware of in a child that has fever and a rash and red eyes, etc., is that abdominal discomfort and vomiting seems to be another condition that is being reported from other institutions as being a pretty common symptom for children with this disorder. Not typically seen with Kawasaki disease, not one of the main things that physicians are looking for, but that's, again, maybe another differentiator that might help us put a patient down one path or the other for evaluation and therapy.
Thank you for that, Dr. Owens. Thank you. Our next question, what are the greatest risks for children who get this condition, and is it treatable?
So some children with this condition seem to stay only very mildly ill. The biggest risks are that some do go on to get more ill, as Dr. Owens mentioned, and they may develop shock or organ dysfunction, including dysfunction of the heart. And so these children may require admission to an intensive care unit. In some instances, they may require assisted breathing with a ventilator or medications to help support their blood pressure and their heart function. Dr. Owens, I don't know if you have additional comments on specific cardiovascular risks, but that's kind of the worst case scenarios that we're seeing of the children who are getting very sick with this.
Yeah, I think, as I mentioned before, that this is a condition that can have those cardiovascular effects of, having lower blood pressure and needing medications to support blood pressure, and having somewhat of a cardiogenic shock type of scenario. Again, in the rarest condition. Now, that being said, at least out of reports of New York City and Columbia, even the children that did have cardiovascular side effects of MISC that needed ICU admission did not require a ventilator to help their breathing. It did not require any real advanced therapies to support their cardiac function. They needed some medication support, some more close monitoring and following of different laboratory values, et cetera. But most of the time, these kids do recover. And most of the time, if you don't need ICU care, it's just supportive therapy like it would be for any other viral infection or post-inflammatory viral infection like you see with Kawasaki disease. These children just need appropriate evaluation, monitoring, and there are some therapies we can get into later that do overlap these conditions. But again, most children will recover from this condition.
Thank you for that. The next question that we have up, we've heard about a lot of these cases in New York. Are there hotspots? And what have we seen in Michigan so far? And are we expecting more cases here?
So the hotspots that we're seeing, so New York being one, really seem to mirror where there have been the most cases of COVID-19, which makes sense. That's one of the reasons we think that there is a link between the two. And since there have been the most cases in the United States, in New York, it makes sense that they're also seeing the highest number of cases of this inflammatory syndrome. As of last week, I had only heard of about 30 cases in total in all of Michigan that were being investigated, with much more being in the Detroit area, which also goes hand in hand with them seeing more cases in the Detroit area than we are here in Washtenaw County. As far as Michigan medicine, we've really only seen 3 to 4 possible cases at Mott so far. It may be that we see more cases as time goes on, but again, this seems to be quite rare.
And it looked like in New York that the time frame from sort of like their peak infections of COVID-19 and the presentation for these children is about 4 weeks that they're starting to see it. And if you look at Michigan's curve, so to speak, we would have expected to see them starting to show up at our institutions about the time that we are reporting them. So hopefully we're not going to see a big upswing in these presentations. And I think it does speak to the rarity of this condition that Liz had mentioned.
Thank you both for that. The next question that we have up, an audience question. After children have recovered from a COVID infection, should they also, like adults, have a cardiac workup too, such as an echo or an EKG?
Yeah, I think that the times where we're going to do cardiac evaluation on these children really is a stepwise approach. Lots of children get fevers, lots of children get colds, and it's really putting these patients into a diagnostic arm where we think that they have MIS-C. And so there's algorithms developed where you have a child who has a fever plus or minus other symptoms like rash, red eyes, cracked lips, etc. That puts us into a presumed MIS-C type of evaluation. We will then start with some other laboratory data, which will include, again, markers of systems, multi-systems, hence it's got its name. So we're going to look at laboratory values that address inflammation, kidney function, liver function, and heart function. And based on those initial screening laboratories, again, it'll help divide a patient into, are we suspected of MIS-C? Do we truly have MIS-C, or do we need more time for evaluation? Those children that do have presumed or suspected MIS-C will undergo cardiovascular screening with EKGs and echocardiogram to look for both function of the heart muscle, function of the heart valves, any inflammation around the heart that might be leading to a buildup of fluid that has been reported in these children. And then even more specifically, again, the relation to Kawasaki disease, looking at the coronary arteries, or the main arteries that feed nutrients and oxygen to the heart muscle, to see if there's any changes there that have been reported with MIS-C. And those are certainly changes that are seen with Kawasaki disease.
Thank you for that. Next audience question that we have up, are there long-term effects seen in kids that get Kawasaki disease, especially in regards to their heart?
So one of the keys to Kawasaki disease is early identification and then early therapy. We do know that Kawasaki disease can cause a dilation or a sort of swelling of the coronary arteries, the large arteries taking nutrients to the heart muscle. And if untreated, and those coronary arteries do get dilated and swollen and actually develop aneurysms, big bubbles in them, that can have long-term consequences, and it actually can lead to basically heart attacks down the road. We know if we can treat these patients early, we can prevent significantly the development of these swollen coronary arteries and really have these childs cured from that disease process without having any long-term sequelae of problems with their coronary arteries if they never get dilated or swollen in the beginning. So the key is, you have Kawasaki disease, you've been diagnosed, you get some therapy, which is intravenous immunoglobulin, IVIG, which then does a great job of preventing the long-term potential sequelae of Kawasaki disease. So if you get treated appropriately, your arteries don't swell, you're pretty good moving forward. Those patients that miss that diagnosis and don't get the appropriate treatment and have some swelling of the coronary arteries, they need some longer term therapy, some more surveillance and monitoring, and there's a greater chance of having some long-term complications down the road. And I guess to follow that up, we are seeing some patients with MISC that have some dilation of their coronary arteries. Some patients maybe have been reported of having aneurysms or big ballooning. What's unknown, because this is such a new condition, is we don't know if our therapies we're doing today are going to really change how these children are behaving months, years down the road.
And I think that's fantastic point there, that this is constantly changing, that even the questions that we deal with now might have further answers further down the line. The next question that we have coming up, what steps should be taken to aid in diagnosis of MISC in the outpatient setting?
So that's a good question, because a lot of these children may first be presenting to their pediatricians. And the Michigan Medicine is actually currently working on an algorithm for the diagnosis of this condition, and it will go from outpatient care to emergency room care to inpatient care. And so really a lot of it comes down to laboratory studies and evaluation, because as we've talked about, a lot of these symptoms may overlap with a viral infection. So a child who has fevers for a few days and some of these other, red eyes and a rash could simply have, a completely unrelated viral infection. And so really getting in to see your pediatrician, or at least speaking with them on the phone sooner rather than later, they can decide if they need to evaluate the child sooner, and then they can decide when to do laboratory studies. And it may be that these children are going to get laboratory studies done earlier than they typically would in the past, just to see what risk they have for development of MISC. And it may be too that they have to go in a couple different times to have labs done to see what the trend is. So are these markers of inflammation that we're looking at, are they getting worse over time, which might suggest that they are developing MISC? And then there's still, I think, debate as to exactly what point do they need to go to the hospital in the emergency room. But I think hopefully our algorithm and our guidelines that we're coming up with, I know that others throughout the country are developing similar guidelines, will help outpatient providers to be able to give that sort of guidance to their patients.
Yeah, I think that's a great description, Liz. And I think a lot of that comes down to communication, and really communicating between providers, communicating widely about what to look for and how to educate our families what to look for. Certainly, persistent fever is sort of that first thing that's going to really take a patient or take a family to want to call their primary care provider to get some more information. It's not just one day of fever; it's 3, 4, 5 days of fever that are high and unrelenting to Tylenol and Motrin that families are going to be using. But that's really the time to call your primary care provider and talk through symptoms, maybe be seen, and then direct for further evaluation from there.
Thank you for that. We actually have a question to something that you'd referenced in the question before this one, Dr. Owens. Is there anything that can be done at the beginning of MISC to protect coronary vessels from potential damage?
Yeah, I think that's a great question. I think all the answers are not known as of yet. But from what we are hearing from our colleagues across the country and even internationally, and from other centers which have had a greater experience with these patients, the ones with real full-blown, obvious MISC that have evidence of inflammation in the cardiovascular system, whether it's fluid around the heart, decreased muscle function, and even more specifically, inflamed or dilated coronary arteries, the most standard therapy people are still doing is very similar to Kawasaki disease, where we're giving the immunoglobulin, the IVIG, to again sort of decrease the body's immune response and leading to some of these changes in the coronary arteries. And we hope that's going to have a positive effect to treat that condition. Now, we've mentioned before, and in the name is inflammatory syndrome. These patients are highly inflamed. And so another very common therapy are anti-inflammatory agents. And very basically steroids that basically tell your immune system to just settle down. We got this externally, let your doctors help out, and hopefully decrease some of the responses that revved up immune system is leading to. And so that's a very standard therapy for these children that are sick and not getting better with MIS-C, are to be treated with IVIG and steroid therapy to both protect the heart and decrease the inflammatory process to help these kids recover faster.
And the next audience question that we have up, I've heard that some kids have tested positive for the new syndrome, aren't testing positive for COVID. What do we know about the connection with the virus, and is it showing up weeks later?
Yes, so as Dr. Owens mentioned, it is about 4 weeks between usually the infection or the known exposure to COVID, and then when children are presenting with this syndrome. And so we suspect it's related to COVID, although it is correct that actually the majority of children are testing negative by PCR, which is typically that nasal swab. The majority of children are negative by that. Only about 1/3 of children in both from the United Kingdom and from New York are testing positive by the nasal swab, which really kind of signifies active infection. However, there's a much higher proportion of children who are testing positive by antibodies, which tends to suggest a past infection or a recent infection. And so even the children who are testing negative by PCR are showing that they probably did have a recent infection that maybe just wasn't detected at the time. Some children are testing negative by both the PCR and the antibody testing, but a lot of those children have at least a known exposure or symptoms that were consistent. And so, I think that there still is this theory that there's a link, although at this point it really seems to be what we're considering more of a post-infectious inflammatory response and not so much caused by active infection of the virus itself.
And I think it's important to remember, just as Liz said, that it seems to be a past infection or exposure. The group out of one of our colleague or peer centers in New York had 40 or so patients that they saw, and they all either tested PCR positive or had antibody positivity. However, the reports internationally and globally show that some patients aren't testing positive for either. But I think it's important for the audience to remember that some of the serology testing specifically, we're still working through those testing specifics, and we might be missing some patients here and there as we're building our testing capabilities and sensitivity to catching these infections or post-infections.
Yes, that's a great point.
Thank you. And we have another audience question up. What if my child tests negative for COVID after a cough or other symptoms, but later has red eyes, red throat, and a rash?
So I think, if children are presenting with these, the fevers, the red eyes, the rash, regardless of whether they have a known exposure or a known infection with COVID, I would be concerned about MIS-C and at least reaching out to their pediatrician and getting evaluated if needed for that. Because as we kind of just talked about, it's possible that, children may have tested negative with the nasal swab initially and still may develop this infection. It also, depending on I can speak to our testing here at Michigan Medicine that our nasal swab is very, very good. It has a very low false negativity rate, meaning that if you have the virus, it's probably going to be detected, but not all tests are the same. And so, I can't speak to the other tests. So even if you tested negative in the past, it's, possible that you could have had COVID.
And as Liz said, I think it's important for any child, independent of previous swabs, independent of any previous cough or cold, if you have persistent fevers, new rash, cracked lips, swollen palms, enlarged lymph nodes, all these other things we're talking about, and really that persistent fever, it's time to contact your physician and get some recommendations. So don't put too much stock in a previous negative COVID test or a previous negative influenza test or RSV test, of new symptoms and persistent fevers and a change in your child's condition. you just want to get evaluated. And maybe in this environment and this condition, we're going to err on being a little bit more conservative and ask that we have some conversation and communication earlier in that disease process.
Thank you. Thank you both. I think that's a very important thing to highlight. The next audience question that we have up, I've heard of cases involving Kawasaki-like symptoms as far back as October. Could it have been COVID?
So based on what we know about the coronavirus, as far as everything that we really know, it seems unlikely that it was circulating that far back. In the United States, really, it seems like it has been more recent than that. And we do see from time to time, even completely pre-COVID, we see Kawasaki disease, and we see certainly in the infectious diseases perspective, we see patients who come in with very similar symptoms, and we can't always figure out what's going on. Sometimes we think maybe they had incomplete Kawasaki disease, or sometimes we think they maybe had toxic shock syndrome, which is another one of these conditions that MIS-C is being compared to frequently, or sometimes we, don't figure out exactly what's wrong with them. But that has been, that patient population has existed even pre-COVID. So I think just based on everything we know about when we really suspect coronavirus, this new coronavirus has started circulating in the United States, that cases in October probably are not linked.
Yeah, I think that's very true, Liz. As new that PIMS and MIS-C and all these things are to us, Kawasaki disease is not new. We see Kawasaki disease all the time. And there are little clusters of disease that pop up at different times of the year in different parts of the country. So from a pediatric cardiologist, a pediatric infectious disease doctor, all the Kawasaki disease in the media that's old school for us. We see that all the time. We treat patients with that all the time. So I think those reports of things happening in the fall of 2019 were probably just Kawasaki disease and unrelated to the novel coronavirus.
Thank you. Another important clarification from both of you there. Thank you. We're going to move topics. We're going to move on to congenital heart disease, high risk questions, things like that. And we have a couple that I'd like to put in together. So the first question is, should parents of children who have chronic illnesses such as type 1 diabetes take extra precautions? And related to that, should grandparents and other adults take extra precautions around children with other conditions?
I mean, I let Liz respond to some of this as well, but I'll, sort of give my 2 cents. I think in general, any child with a chronic condition usually takes extra precautions regardless. If you're a patient that has congenital heart disease and has significant residual heart conditions, we're always instructing our families to take extra precautions to avoid sick contacts, to use good hand hygiene as much as you can, depending on the age of your child. So I think that anybody who has a chronic condition, whether it's congenital heart disease, kidney disorder, liver disease, or immune deficiencies, are certainly at an increased vulnerability. And I think that the standard increased cautions and precautions that our families take should be continued to be done in this environment with maybe even a little bit more conservativeness. I think we're in an unknown time here in our society and doing things that none of us expected we would ever be having to do to combat a pandemic and a virus. So being extra cautious during these times makes a lot of sense.
No, I agree. I think Dr. Owens is exactly right. I don't really have much more to say. On top of that, I think children who have these conditions, we know, may be at increased risk, certainly of complications from COVID. We don't know at this point of what might pose increased risk of getting MIS-C or getting worse symptoms of MIS-C. But really the way to prevent that is to avoid exposure in the first place. So from both accounts, really kind of being diligent about taking those precautions, social distancing, maintaining your 6-foot distance, wearing a mask when possible, washing your hands, don't touch your face. All these things that we've been hearing about are just that much more important for children who might be at more risk.
And Ed, you might be wanting to follow up maybe specifically with congenital heart disease patients, and especially since we've been talking about some of the cardiovascular complications with MIS-C. So far through reports, we haven't seen that patient population being handling the condition differently or being more susceptible to MIS-C. But certainly if a child has, again, a heart that already has some decreased function or already has some problems maintaining the normal cardiovascular function, they may be more vulnerable if they get MIS-C, if they get influenza, if they get any other viral condition that leads to inflammation. So certainly want to use some extra precautions for children that have some vulnerabilities from a congenital heart disease standpoint. But it does not seem that having congenital heart disease predisposes getting these conditions at this point. Again, with very small numbers that we're seeing, it's hard from an epidemiologic standpoint to really understand which patients are more vulnerable and what are the risk factors for being more sick or less sick.
Fantastic. You answered my next question there, Dr. Owens, and we have one that's related to that. Do you know of any cases reported in kids with a single ventricle anatomy or other congenital heart defects? And if so, what were the outcomes?
Yeah, I haven't heard of any reports through the major congenital heart centers across the country as of yet for our single ventricle patients having MIS-C. There have been a few reports of some patients with single ventricles having COVID-19, sort of positive PCR swabs and having sort of that primary infection. But we haven't heard any reports about the single ventricle patient population having MIS-C. And when I say we haven't heard any reports, what's I think truly amazing, and Liz can probably speak to it in her discipline as well, is the communication that's going across the world, sharing information about these various conditions, whether it's the adult COVID-19 infection or MIS-C infection in kids. There's just so much collaboration, and we're all just trying to share information, share experiences to help one another and help our patients. And so far, we haven't seen those reports popping up. So speculating on how, a patient with a single ventricle physiology would respond to that inflammatory condition, I would just be speculating. But I think families that have kiddos with single ventricles, know that they are more vulnerable to our sort of run-of-the-mill viruses that we deal with every day. And might have an increased response to that condition.
Yeah, and just to piggyback on what Dr. Owens just said about the communication going on. So we actually have, later this week, we have a virtual meeting with all of the pediatric infectious disease doctors throughout the entire state of Michigan. And really, I have never seen anything like that happen before. And so it really just goes to show the collaboration. We're learning so much since really at Michigan Medicine, fortunately, we haven't seen a ton of these cases. We're learning so much from our colleagues who are seeing these cases. And I think it's just been a testament to how well our medical system has been working together.
I think also some testaments to our overall community, whether it's, my niche of the congenital heart disease community or just our community here at Michigan Medicine, Washtenaw County, et cetera, doing a great job social distancing, staying at home when we can, and really, flattening that curve so that we aren't having to deal with an influx of hundreds of patients with MIS-C, because really preventing that exposure is really what's going to prevent that inflammatory condition in the long run.
Absolutely. It's getting a little bit close to 2 p.m. now. I make it 1:53, but since we got a late start, if it's okay, we'll go a little bit past 2 p.m. to address some of these everyday questions on returning to normal. So that's going to be our next topic. So let's look at returning to normal questions. My family has been self-isolating since the start of the pandemic. What steps should we be taking as states start to reopen and return to normal? I'm scared to take my family out, but of course, I'm also eager to get out.
So fortunately, as Dr. Owens had just mentioned, Michigan as a whole has actually done very, very well flattening our curve. And we're seeing a decline in new cases of coronavirus here. So I am hopeful that there are ways that we can start to get back to normal as safe as possible. However, it's important to keep in mind that there will still be at least some level of risk as long as coronavirus is still circulating in the population. And so being aware of the measures that you can take to really decrease your risk is going to be important. And so think about what activities you're doing. Different activities will have different amounts of risk. So whether they're indoors or outdoors, the amount of other people who are present, how close these people are gathering, how well other people in the vicinity are adhering to recommendations. And, you know, the amount of risk that is acceptable is going to differ from person to person. So really thinking about for yourself and for your families, what degree of risk are you willing to deal with. So fortunately, the CDC and our state health department have released really extensive guidelines for how businesses, recreation areas, schools even can reopen as safely as possible. So before you go out to a new place as you're kind of getting back into your normal routine, I recommend that you reach out to these places and you know, make sure that they're following all the recommendations put forth by the CDC and the state health department. Check in what other safety measures or cleanliness measures that they're implementing to keep everybody safe. And then really, just be aware that really the recommendation for now is still to wear the mask when possible in public, still to, keep your 6-foot distance. And so, avoid gathering in large groups or in crowds, avoid touching your face, etc. And just be aware that as more and more people start to get back to normal, watch for symptoms developing. And if you or your family is sick, please stay home. And so those are kind of the initial recommendations that I would have for people as we're starting to sort of hopefully get back into our normal routines.
And of course, since lots of people maybe listening are talking about children and trying to prevent MIS-C and so forth, it becomes even harder when we talk about trying to wear a mask on a 2-year-old. Although that's not recommended, but just making a point that most toddlers don't want to walk around with a mask. I do think it's important, as Liz said, to really avoid those sick contacts. Or make sure that if you are going to small family outings, that the adults are wearing their masks and the adults are following the recommendations from the CDC and the public health organizations, even if the child is not, so that at least that degree of protection is there as you're thinking about leaving the home as things are starting to open up.
Fantastic points there. The next question we have, with summer around the corner, I'm thinking about letting my kids play at playgrounds, have more play dates, and go to summer camp. How can I keep them safe and healthy in these environments?
So, some of the things that we've just talked about, making sure that with it, any summer camp or daycare or any sort of childcare, that you're checking in with them about what measures that they're going to be taking, make sure that they're aware of the recommendations put forth by the various public health entities and following those. Make sure that, for your older children, have the discussions about the importance of personal space and hygiene and hand washing and all of those things. Of course, younger children, I think, won't be able to fully grasp these concepts, but doing your best when you're taking them out to the park. If there's 50 children at the park, maybe that's not the best day for it. I'm still trying to make good decisions about trying to avoid as much potential exposure as possible.
Absolutely. And the next one, this is a little bit of a follow-on to your comment about masks, Dr. Owens. My child won't wear a face mask. I'm worried about taking them out in public without one. Any suggestions? And related to that, we have a newborn. Should adults wear masks while holding our baby?
So it is recommended that children who are over 2 years of age wear a mask unless they have certain medical conditions. So if they have any conditions that make it difficult for them to breathe, or if they have any condition where they cannot remove the mask themselves, then they should not wear a mask. But for those older children who will do it, it really is best if they can. That said, I understand you may not be able to keep a mask on your 3-year-old child, and that is something that you'll just have to work around as much as possible. So as Dr. Owens had mentioned earlier, try to do your best to make sure that if they are having to go out, that, you're staying away from other people, that people who are, around them are wearing masks, and doing everything else within your power to kind of decrease their potential exposure.
And I guess I would defer, maybe we'll have to do some follow-up on the recommendations about mask wearing in newborns. I don't have any specific information on that. I don't know if Dr. Lloyd does or not, but I would defer to maybe looking at some other of the public health recommendations.
Yeah, that's a good question. And I actually, forgot that was part of the question. I haven't seen any specific guidance for that instance. I think it certainly wouldn't hurt if the adults are willing to do that. Fortunately, though, infants have tended to do pretty well. But I still think that if the adults are willing to wear a mask, it's probably, it certainly wouldn't hurt, and it may help. So.
And I think even before the COVID pandemic, if you had a newborn and a sick grandpa, you probably told the sick grandpa that you can't visit grandson or granddaughter for a little bit, or if you're going to, maybe you should wear a mask.
Right, absolutely.
Important points there. Thank you. We're going to move on to our next topic, which is routine healthcare. Pediatric clinics are ramping back up. How important is routine pediatric care right now?
So routine pediatric care really continues to be as important as ever. We're really encouraging patients to stay up to date with their well child exams, their immunizations, and other routine medical care. You really should not be afraid to take your child to the doctor, whether it's for a well child exam or a sick visit if needed. And please don't delay in seeking care if you really feel like your child needs it. Our doctors' offices are taking the proper precautions to really ensure the safety of all of their patients. If you're still nervous about it, please give them a call. They can talk with you about the steps that they're taking to make sure that they can deliver care in a healthy and safe manner. But really, we have seen, in Michigan, we have really good vaccine tracking. And so one of the things we've seen is that a lot of our children are now falling behind on their vaccines, which then could set them up for all kinds of different infections later on if they're not well protected against those. And so really trying to avoid that, we're trying to avoid missing other medical conditions that could be caught on a well child exam. We do recommend that you work with your pediatrician to keep your child up to date on all of those routine medical care.
Fantastic.
I would just echo too what Liz had said about that it's safe to go to your doctor, it's safe to get evaluated, because it's just been truly amazing to see the adjustments that medical offices have done now, and the changes that, from all the staff and everybody working to really protect our patients, to protect ourselves and protect the staff. It's truly remarkable. There's definitely changes. There's adjustments to be made on both ends, from the offices to the patients, and how intake is and what waiting rooms look like. But it is safe to get care, and that care is still necessary. We really want kids to be evaluated and keep themselves protected now, but as Liz said about vaccinations, keeping them protected in the future as well.
Absolutely. This is something that you touched on, but this question is very related to it, so it's worth circling back and repeating again. This question: my children have several upcoming appointments at U of M. I'm concerned about exposure risk bringing them to the hospital or clinics.
Yeah,
go ahead. No, go ahead.
I was just going to, sort of echo what I had just said. I think that the changes we've done here at Michigan Medicine have been tremendous to keep our, primarily our patients safe and decrease any significant exposure risk. And so there's a lot of changes here to ensure that to our best of our ability. There's also opportunities for certain situations to do virtual visits, to do things online or on the phone, so that we can avoid exposure if it's not necessary. So we are looking at every individual patient that has appointments at Michigan Medicine and deciding, what the pros and cons are of having a patient come in, although we think it's very safe. But if it's unnecessary, we can find other avenues to evaluate your son or daughter.
Yep, I don't have anything else to add. That was perfect.
Perfect. And the next question: what should parents do if their children show signs of COVID-19?
So whether you're seeing signs or symptoms of COVID-19 infection or signs and symptoms of MIS-C, really what they should do is call your healthcare provider and really call them sooner rather than later. Nobody's going to fault you for reaching out on the early side and discussing. Most of these children are going to do just fine, honestly, but your providers may want to evaluate them sooner rather than later, even if it is just by a video visit at first. They may want to get blood work sooner than they otherwise would, especially if they're worried about possible MIS-C. But of course, if you're seeing any very concerning signs, such as difficulty breathing, turning blue, any severe pain, extreme sleepiness or confusion, then don't hesitate, take them to the emergency room right away. But really, other than that, reaching out to your healthcare provider sooner rather than later and discussing. And even if the discussion is just, we'll continue to watch them and check in with you tomorrow, I think it's better to have that conversation on the earlier side.
Fantastic. We have a question from someone who asks for clarification on, should children wear a mask outside or just inside? When are filters in the masks necessary? And do I need a filter in my cloth mask when I grocery shop?
So the question about, let me break this down. So the first question about, do children need to wear a mask outside or just inside? Certainly, if they're inside in outside of their home in a building where there's other people, then they should absolutely wear a mask. Outside, I think, is a little bit less strict, but if they're going to be coming in within 6 feet of other children, other people, they probably should still wear a mask. And that's just, again, to prevent that exposure that you can get. Even if they're, running around on the playground, if they're coming within 6 feet of other children on the playground, it is a potential risk, even though we think that outside, there may be slightly modified risk compared with inside. And then can you repeat the second kind of parts of those questions?
Yeah, so the first one was about children wearing a mask outside and inside. And the second part, when are filters in the masks necessary? And do I need a filter in my cloth mask when I grocery shop?
Okay. So really just a simple cloth mask will, the reason for wearing the mask is that COVID-19 is spread primarily by droplets. And a simple cloth mask will filter out large droplets. The only time when additional filters are needed, such as these N95 masks, is if you're involved in a medical procedure where there's a chance that the virus could be aerosolized. So really outside of healthcare providers, nobody should necessarily need any additional filters in their mask. And the other thing is that when you're using an N95 mask, you actually, to wear it properly, you need to be fit tested. So it has to be fitted to your face and you have to be trained to wear it. And so if you're wearing one of these kind of more special masks without having been properly fitted or trained to do it, it's probably not providing any additional benefit anyway. And I can tell you from experience, they're very uncomfortable. When I have to wear one, I cannot wait to take it off. And so if you're messing with it or readjusting it, certainly if it's a child, they're not going to want to wear that. They're going to be messing with it. Then you're losing all potential benefit anyway. And so for those reasons, really just kind of a standard cloth mask, surgical mask, those types of things should be more than fine.
Thank you for that. And as we move towards our close of this, as we move towards the end of our chat, is there anything that you think we've missed?
One thing that I would just emphasize is that, we've said this is a constantly changing situation. And so what we know is going to change even day by day. So as best as you can, stay updated so that if there's changes that you should be aware of, that you are aware of those changes, not only from the standpoint of COVID-19 and MIS-C infection in kids, but also from the standpoint of as we kind of open the economy back up, the recommendations from the public health entities may change as well. And along those lines, there's a lot of misinformation out there. So do be sure that the information you're getting is coming from a reliable source.
Fantastic. Anything to add, Dr. Owens?
Yeah, if I could just find my unmute button. I can't believe I lost it after this hour of conversation already. Yes, I would just echo what Liz had said. And I can maybe specifically about MISC too, is I do think that continued communication is important, because we do know that if you've had a phone call with your primary care provider, but things change, it's important to provide updates. Similarly, if you're in the hospital, we're going to continually update ourselves on the patient's clinical condition, because we have seen, again, a vast majority of these patients will recover quickly, but there are some patients that go the wrong direction, and they can go down the wrong direction quickly. And so we need continued updated communication so that we can respond to that change and provide the care necessary. Again, nothing to panic about, but just things to be aware, be observant, and communicate with those around you that are available to provide help.
Fantastic. Well, thank you for both of you for joining us today for this great discussion. Thank you for your patience during the technical difficulties. And that also goes for our audience as well. For more information and resources to help navigate this difficult time, please visit motchildren.org/COVID update for parents. That's motchildren.org/COVID update for parents. Thank you very much for your time and your expertise, Dr. Lloyd, Dr. Owens. Thank you very much.
Thank you.
And thank you, Ed.